welcome everyone to today's session, which is going to be very exciting. I wanted to just bring your attention to some upcoming events before we get started and before I make my introduction. The next in our series of virtual grand rounds will be held on April 19th. It's a rising star on our team, Sunil Patel, who will be discussing potential environmental causes of bladder cancer. And then I also wanted to remind you of our series of women's programs that are based down at Sibley Hospital. Upcoming on June 7th, we have a special treat for you. Elizabeth Platts will be joining us. You remember her if you saw her during our Grand Rounds series. She's a very animated speaker, and we'll have a very exciting talk for you. If you have any questions, just remember to email us at bladdercancer@jhmi.edu, or to find our programming online, just Google Johns Hopkins Greenberg Bladder Cancer Institute. So my guest today really needs no introduction. You'll all, I'm sure, have seen Dr. Brawley in one way or another. Dr. Brawley is the Associate Director of Community Outreach and Engagement for the Sidney Kimmel Comprehensive Cancer Center. He's a professor of oncology, and he's also a Bloomberg Distinguished Professor. He leads an interdisciplinary research effort on cancer health disparities, and he has a long history, long, strong track record of amazing contributions, a long distinguished career. He also happens to be a genitourinary medical oncologist, so I spend Monday mornings with Dr. Brawley during tumor board. And so, Dr. Brawley, welcome very much. It's a pleasure to see you, and I look forward to having this conversation with you today.
Well, thank you, David. Please call me Otis. You know you can call me. It's wonderful to be here and talk about health disparities and the things that I do for a living, the things that really, my fire in the belly is health disparities and how we can overcome them. So thank you for having me.
Sure. And so maybe we can open up by having you tell us what you mean when you talk about quality cancer care and access to it.
Yeah, well, sure. Well, what I really worry about, and much of the work that I've done over the last 30 years, is actually to demonstrate that outcomes are different amongst various populations because certain populations don't get high quality care. Now, high quality care is defined in my world by the NCCN, the National Cancer Comprehensive Network. And it's a network of 20 some odd comprehensive cancer centers, of which Hopkins is one. And they send their experts in a particular disease. And you can go online. You can go on nccn.org, see how stage 1 breast cancer should be treated, or how stage 2 bladder cancer should be treated. And when I say people should get adequate high quality care, they should be treated according to those guidelines, or they should be in a widely recognized clinical trial that's trying to advance those guidelines to the next level.
Makes great sense. And so how successful are we in providing that kind of care?
Well, unfortunately, and it really tends to be more socioeconomic, there's a substantial number of people in the United States who get less than optimal care for cancer. In breast cancer, for example, it's 30% of women who are treated for breast cancer. When you look at what they get, there's something wrong in the treatment that they receive. I mentioned breast cancer because it's a common cancer. You can get treatment for breast cancer at virtually every major hospital in the United States. But still 30%, I didn't say 30% of Black women, 30% of all women with breast cancer have something wrong with their treatment, be it the surgery wasn't done right, the appropriate markers were not sent from the lab, perhaps the pathologist didn't do the pathology correctly, the chemotherapy was dosed inappropriately. The radiation beam was not aimed appropriately, or one major problem in the United States is a lot of poor people are treated with radiation therapy machines that are older and have less energy than the newer machines. And then, of course, compliance issues or adherence issues are a problem. People dropping out of care. You know, when we're giving chemotherapy, dose intensity is really important, getting the chemotherapy on schedule. Well, oftentimes because of transportation issues, poor people don't get the right chemotherapy dosages because they can't make it to the clinic every week or every 3 weeks or whatever the clinic schedule is. And unfortunately, this counts for why poor people end up doing worse than non-poor people. And we can talk a little bit about the numbers of how many people are the desperate population and where they live as well. You know, when I was at the American Cancer Society a few years ago, we tried to quantify how many people die a death that they don't need to die. That's disparities, right? Of 600,000 Americans who die from cancer in a given year, 130,000 or so don't need to die. It's that big. It's 22% of all deaths in cancer could be avoided if we could just get high quality care to all Americans. Now, the 130,000 or so, they live much more in the southern United States than anywhere else, but they live in every state. Somewhere between 70 and 80 of the 130,000 are white Americans. We frequently think of minority health as the issue. David Satcher changed it to health disparities. Others have changed it to health equity. And now there's a movement afoot to call it health justice. It's really getting everybody the care every human deserves. Now, a Black American is more likely to suffer health disparities, but the largest group of people to suffer health disparities are white Americans.
Thanks for that. So I'll also welcome Stephanie Greenberg, who is going to join us for this discussion. Stephanie, would you like to ask a few questions?
Yes, and thank you, Dr. Brawley. What David didn't mention is you were just named, you're a big deal, and we love you, and we love the work you do. So along with, everyone's heard Dr. Fauci and Dr. Francis Collins, but our own Otis Brawley was named to STAT, which is an important organization that rates or honors excellence. You were just named to one of the country's most influential thought leaders in science, and we're blessed to have you. You've written several books, and you lecture extensively, and you are prolific, and we're again blessed to have you. And of course, you were with the American Cancer Society for many, many years, and now we claim you as our own. So I have some questions for you that you may have already touched upon, but our audience today is we all consider ourselves one big family, people touched by bladder cancer or those caring for patients with bladder cancer. And we are the patients in this talk. And I think those listening, we're humbled that you're listening, but we also want to have your beautiful words be of service to them. So I may have you repeat some things, but in the context that the people listening are our patients, and we need to serve them. And that is our mission at the Greenberg Bladder Cancer Institute. In 2012, you wrote a book. I love the title. It's called How We Do Harm, A Doctor Breaks Ranks About Being Sick in America, where you call out rightfully, very bravely, I might add, the flaws, inequities, and inconsistencies that make up the American healthcare system. And you did touch on some of them right now. In your book, you claim the system to be in a state of perpetual failure, given the outsized role that the pharmaceutical companies and insurance companies play in deciding care for patients, be it paying or not paying for expensive new immunotherapy drugs or just regular drugs, dictating what can and cannot be allowed, and not allowing for second opinions often, which for bladder cancer patients can be devastating because for bladder cancer patients, especially just in pathology alone, almost 20% are misread. So at Hopkins, not to plug our great pathologists, they only do bladder cancer and they see an error rate of almost 20% in the second opinion service, which is really almost devastating to us. But if you are not allowed to get that second opinion paid for by insurance, you don't get the second opinion. So that's why I bring that up. And also you call out the profit motives of doctors and hospital systems. No one is spared by Dr. Brawley, and even overzealous patients who want to consume far too many healthcare services. You are a proponent of what you call rational healthcare and not rationalizing healthcare. So for our audience today, listening in, how can they ask for and get rational healthcare?
Yeah, rational, not rationing. Rational healthcare is looking at things like the NCCN and what should I be getting. It's trying not to be over imaged. We do a lot of extra CT scans and MRIs and other things that are unnecessary. We sometimes operate when we shouldn't operate. I'm talking about the global, all of us in medicine. And by the way, you're absolutely correct that a substantial number of bladder pathologies especially, but we see it a little less, but still in things like breast and colon cancer. The pathologists at Hopkins or the major centers like Memorial Sloan Kettering, Dana-Farber frequently find something different from what's happening in what's called in what I'll call the real world, the community hospitals. And you put your finger right on it. It's better to have a pathologist who only reads bladder versus a pathologist who's going to read a bladder cancer, then a breast cancer, then a colon cancer. By the way, my book was well received by doctors, and I got a few awards from people like the American Society for Clinical Oncology for writing it. I like to point that out because it means there's a whole bunch of people in medicine who want to do the right thing and want to provide high quality care. In terms of second opinions, the Affordable Care Act, also known by some people pejoratively as Obamacare, does allow now for people to get second opinions for cancer treatment. The insurance companies can no longer say you can't do that. And so those are all good things. But I would ask every patient to try to learn about the disease that they have. Try to learn what the treatments should be. Go to good sources. Go to the National Cancer Institute webpage. Go to nccn.org. Don't just Google around because you can find a lot of garbage if you just simply Google, but go to the good places, the reputable places, and read and learn about your disease and try to have a good conversation with your doctor about the disease. You're going to bring out the best in your doctor by having that conversation, showing that interest. And I'll also say, if your doctor doesn't want to have that conversation, maybe you ought to find another doctor. That's how people get the best care. And then when something is recommended, say, do I really need that intervention? If the answer is yes, then get it. If the answer is, well, then have a longer conversation before consenting.
Fantastic advice. The National Cancer Act, President Nixon's war on cancer, you were barely born, I bet, is now 50 years old, which is amazing. And it is a hallmark achievement in American society. I think you would agree. It's pretty amazing that in 50 years, I hope you agree that immense progress has been made and we're all better for it. However, much has been done in the past 50 years. And you were also unafraid to mention that you believe there's, drawing on just what you just said, there's a practice gap in cancer, in that there have been tremendous discoveries and therapeutics and yes, new bells and whistles, and also proven remedies that have been successful and maybe not that sexy for cancer care. And we're talking about all cancers here. But you believe that many, many people who qualify and who are eligible, because of the way the system is set up, fall into a practice gap.
Yeah.
Can you explain this and what can our patients do about that if they feel that they're in a gap?
Yeah, unfortunately, the gap is so often driven by socioeconomics. That means that they end up getting what I'll call less than optimal care. And let me give you some examples where patients may not even know about it. Let's go to colon cancer here. And we end up with things like, the American problem with race comes into play and so forth. In the 1990s, it was widely accepted that colon cancer, for some reason, was more aggressive in Blacks than in whites. And the reason for that was stage 2 Blacks after surgery are more likely to relapse and die compared to stage 3 whites. And this was widely accepted. I even accepted it myself. Then there was a young surgeon named Kimmel, who's at the University of California, San Francisco in the early 2000s. She started realizing that equal treatment yields equal outcome at the University of California, San Francisco. Blacks do equal to white. Then she went to Stanford. At Stanford, Blacks do equal to whites. But in the California registry, the whole state of California, Blacks who are stage 2 are actually more likely to die than whites who are stage 3. And she said, how could this be? Well, she ultimately figured out that the Blacks are less aggressively staged. For those who are technical, the average number of lymph nodes looked at in Blacks were 6, and they were stage 2 because they had no cancer in 6 lymph nodes looked at. Well, the average number of lymph nodes looked at in whites was 18. And there were a lot of stage 3 whites who were stage 3 because they had 1 lymph node positive and 18 looked at. Literally, the Blacks were not as well staged as the whites. The whites were 3 times more aggressively staged, you can say, on average. And she's a surgeon. She said, I know a whole bunch of pathologists. They're not racist. How can this be? Well, it turns out in California, about 80% of Blacks with colon cancer are treated in about 15% of the hospitals that treat colon cancer. And the average number of cases per day that a pathologist sees in those hospitals is 6 per day. In hospitals where whites are being treated, which are wealthier, the average number of cases per day is 1.5. You see, it's the pathologist is overworked because they're in this hospital, which is overrun and resource poor. But that's where all the poor people who have Medicaid and poor insurance are getting their treatment. What I'm talking about is how there's a socioeconomic disparity here. It really is a form of segregation by socioeconomics that led to, and of course, all of us were more than happy to believe that this was all because colon cancer is more aggressive in Blacks than whites. But the key was, in places that provided equal treatment yielded equal outcome. And by the way, I can say that for lung cancer. I can even say that for prostate and bladder cancer. When you look at Blacks who are treated at Hopkins or Memorial Sloan Kettering or MD Anderson, their outcomes are the same as whites. So again, we need to work to try to get adequate care to all human beings. And I'll come back and point out, I just talked Black and white, but it's really rich, poor. And the largest number of people who end up getting the poor treatment are white Americans.
So if I may interject just a sec too. So for bladder cancer, staging is done by TURBT a lot of the time. And TURBT is an art. And so access to a good TURBT with muscle in the specimen is critical for staging patients. And so I imagine, Otis, that the problem could even be a lot worse for patients with bladder cancer.
Yeah, when you're talking about the more common cancers, bladder cancer is what, 5th in men, 10th in women.
4th in men. Yeah.
4th in men now?
Yes, it's
Yeah,
gotten more notoriety.
when you're
sadly.
talking about prostate, lung, colon, I would expect that there's more people familiar with how to do the staging. You really need a specialist when you start talking about bladder cancer.
Yeah, absolutely.
Leads me to my next question, if you allow me. You speak so eloquently about the notion of cancer justice, which is a beautiful term that really encapsulates all that you've worked your whole career on and what you've just explained to us. And one of the statistics that you share is that very much like what you were just talking about, but slightly different, is that 85% of patients are treated in community settings, not necessarily rich or poor settings, just community settings. And in the bladder cancer community, we're finding that most patients, and I can say this anecdotally, and I think David will agree and our team will agree, are coming in through a referral system. The first stop would be your local urologist in your local hometown, who all of a sudden, says you have bladder cancer, and they hadn't seen very much of it before. Although the numbers belie that, because it's about 80,000 and growing per year, sadly, and growing in women as well. Given that so bladder cancer is often diagnosed in a community setting, which often does not have the resources or maybe even the updates to implement the latest advances in care. And happily, I think David will agree, I'm a little overexcited about it. I think there's been immense progress in bladder cancer in the last 5 or 6 years. But in the community setting, we find and we see and we refer out to academic medical centers, not just Hopkins, for sort of better care. How can a newly diagnosed bladder cancer patient in their own hometown, far away from Hopkins or far away from Moffitt or Sloan Kettering, what advice can we give them to be a better informed patient, and what to ask for most of all?
Sure. Well, first, I would hope that they were being seen in a hospital that was certified by the Commission on Cancer, which is the American College of Surgeons Commission on Cancer. They actually visit hospitals and they audit how they take care of cancer patients. And they also do some work with doctors who are affiliated or have admitting privileges to those hospitals. And they have certain standards, like you have to have a quality control program, you must have a palliative care program, you must have a pain management program. That tells you that your hospital, and by the way, it's only about 60% of hospitals that are certified by the American College of Surgeons Commission on Cancer. Secondly, if your doctor participates in clinical trials, we have got good data to show that that doctor takes better care of all of his or her patients compared to a doctor that does not participate in clinical trials. Putting 2 or 3% of one's patients on clinical trials means that you take better care of the other 97%. Now, let me explain why. Clinical trials are a way that doctors do continuing medical education. It's the only real time when someone is rigorously looking over the doctor's shoulder to make sure that the chemotherapy, in my case, I'm a medical oncologist, was dosed appropriately and administered appropriately, that the surgery, in the case of a urologist or a surgeon, was done appropriately, the pathology was done appropriately, the appropriate number of nodes was looked at, there was an assessment to make sure that all the margins were clean and there was no cancer, no evidence of cancer left behind. Clinical trials are the only time when somebody's really looking rigorously over the doctor's shoulder to make sure those things are done. And if you have that kind of, if that's being done in just 2% of your patients, yet take better care of all the other patients. It makes you more rigorous in taking care of those patients.
That's stunning. Thank you for those tips. And it's a little sobering, but I'm happy to report self-servingly that at the Bladder Cancer Institute, most are involved in their own clinical trials. And we have a whole roster, robust clinical trial department run by our own faculty. So that's good to know, as well as at most of the academic medical centers. Now a dilemma. You are a giant proponent, and for which we thank you, for screening and prevention. Certain cancers have the benefit now of having screening tools, mammograms, PSA tests, colonoscopies. Bladder cancer isn't quite there yet, although Dr. McConkey here is working hard on it. They just had a conference about biomarker development and the dream, everyone dream with me. You can tell if you have bladder cancer by a simple blood test or a urine test, nothing more, right? Wouldn't that be great? And it's coming, but not yet. Given that bladder cancer presents when you have it and you don't even know you have it, not unlike pancreatic and other cancers, what do you advise patients who, what about the other screenings? And the two-part question is, we've just gone through a pandemic and screenings were vastly delayed, I imagine. Can you explain post-pandemic or in pandemic screening and the importance of screenings when we have them? And sadly, bladder cancer is coming along, but slow.
Yeah, well, for screening, you have to look at each specific disease. And you have to be careful with certain diseases. For example, the South Korean experience with thyroid cancer turned us off to thyroid cancer screening altogether. What they did in South Korea was the Samsung company, the TV people, and washing machines as well, I guess. They started having these McDonald's-like screening centers all throughout South Korea, where you could go in at 9 o'clock and have screening for a number of different things. They would do endoscopy for stomach cancer, colonoscopy for colon cancer, spiral CT for lung cancer, mammography, cervical screening, everything you can think of. One thing that they did was they ultrasound people's thyroids. And they started doing this on a number of sites in the 1990s. The first site was put there in 1993. In South Korea, the incidence of thyroid cancer in 1993 was 5 per 100,000. The death rate was 4 per 100,000. Those are real numbers. In 2011, the incidence was 75 per 100,000, and the death rate was 4 per 100,000. Yes, they were finding more thyroid cancers, but they weren't finding more thyroid cancers that killed. And that's the lesson. In prostate cancer, that's why you know now over half of the prostate cancers that we diagnose, we watch, we don't treat them anymore. Because yes, they are cancers, but they're the kind of cancer that doesn't kill, which is hard for some people to think about. And so these blood tests, and I've been working very hard with Grail on this, these blood tests for screening, we've got to make sure not just that they find cancer, but they find cancer so that we can intervene and prevent someone from dying. That's the part that's the hard part. Now, we have certain screening tests that we know save lives right now. We hope we can get there with colon cancer in a very short period of time. And we would love for people to be, by the way, in a program of screening. I see too many women who now want lung cancer screening because they smoke, but they forget about breast cancer screening or cervical cancer screening. We want people to be in a program of routine screening where they regularly get all the screening that they should get. For men, that's colon cancer screening. For men who were smokers or are smokers, hopefully they'll quit if they are smokers. That includes spiral CT of the lung. Prostate cancer, all the major organizations say men should be told of the potential risks and the potential benefits and make a decision about whether they want to be screened. So those are the things people should be doing right now. I am a bit concerned that over the last 2 years, we've had a large number of people who have gotten out of their routine of screening, and we are going to have some additional metastatic disease over the next year or two because of the COVID epidemic. I'm also concerned, we're already starting to see this, that there's some people who had cancer who dropped out of treatment during the height of the COVID epidemic, especially in 2020 when there was no vaccine. And some of those people are now with metastatic disease and are not dying of COVID, they're dying of their cancer because of failure to get treatment a year and a half ago. So yeah, I'm very concerned about that. My message is, and by the way, we're not a resource wealthy world. There are a whole bunch of people who would love to get screened now for breast cancer or cervical cancer, and they can't get into the doctor because the line's too long. So that's a real problem as well, but it is a huge concern.
Wow. Humbling. I'm going to actually ask Dr. McConkey a question because you mentioned watchful waiting in prostate cancer. And it's my understanding there's a movement underway, David, to do watchful waiting in some kinds of bladder cancer. And as our audience knows, bladder cancer requires intensive follow-up and treatments. It is the most expensive cancer to treat. You know, that's someone else's business, but it's a pain in the neck and it's burdensome and it's stressful and it's just stinks. So everyone out there, we're with you. But David, talk to us about the possibility for certain early stage bladder cancer, watchful waiting, and could that be a new norm in your mind? So
yeah, well,
Mr.
Noah Hahn is complicating that for us because in his clinical trial with his FGF receptor inhibitor, he's seen very exciting activity, complete responses in patients with low and intermediate risk non-muscle invasive disease. These are the tumors that have the most activating mutations in them. So yes, there are cancers that will never kill you that develop in the bladder. And those cancers are the ones that cause patients exceptional concern because they have to come back in all the time to get cystoscopy surveillance. So if there were a way for us to watch patients who have very low risk disease and not continue to torture them with cystoscopies and other interventions, that'll be a big deal for us. And the other opportunity, as everyone knows, is bladder preservation. So there is a fraction of patients, a significant fraction of patients, who can be cured with surgery alone. There's another fraction that can be cured with bladder sparing radiation therapy. We're doing a clinical trial right now with trimodal radiation therapy plus a checkpoint inhibitor. And there are even patients with more advanced disease that can be cured with neoadjuvant chemotherapy. So we are very anxious to watch as many of those patients as we can after they've received, as Otis was saying, level 1 evidence-supported frontline therapy. That's key.
Neoadjuvant chemotherapy is chemotherapy given before surgery, which is really it's really a wonderful thing sometimes because you give the chemotherapy and then you go to do the surgery and you find out the tumor's all gone.
Exactly.
And that's a wonderful thing. Now, you were talking about the National Cancer Act. Richard Nixon signed the National Cancer Act on December 23rd, 1971. We've gotten a whole bunch of things out of the National Cancer Act. David just mentioned several markers that we have drugs for. We learned about these markers because of research that was done slowly and laboriously over the years. You know, in breast cancer, the first marker we ever learned about was the estrogen receptor. And then we got in 1981 an estrogen receptor blocker called tamoxifen. And now we have aromatase inhibitors and other things. The other thing that we learned talking about this cancer that doesn't need to be treated is we learned about the molecular biology of cancer. And in doing so, we went from a mid-19th century definition of cancer that the German pathologists gave us literally in the 1850s with a microscope, to a 21st century definition of cancer that involves not just the microscope, but what's going on in terms of molecular biology inside of the cancer. And this has been taken further in breast cancer and prostate cancer. And David McConkey is going to bring us there in bladder cancer shortly. You know, when I have a prostate cancer patient, I can send his biopsy to a lab and they look at 21 different genes and they say gene 1 is turned on, gene 2 is not, gene 3 is turned on, and gene 3 is turned on and overexpressed. They look at all 21 of those and they create a profile for that prostate cancer. And then they come back and tell me, yes, this is prostate cancer, but this is the kind that God meant for this man to die with and not of. Or, yes, this is prostate cancer, and this is the kind that you need to treat. And so the definition of prostate cancer is now not just pathology under the microscope, it's objective looking at the molecular biology. We're going to get there very shortly in bladder cancer and be able to reassure that poor guy who's getting, or gal, who's getting cystoscopy every year that it's worth it.
Yep, absolutely.
I'm gonna ask my last question. I could keep you here for hours and hours, and I hope everyone's enjoyed this. And we have some questions, I believe, in the chat. But with the anniversary of the 50 years of the National Cancer Act, are you optimistic about the future, given disparities, prevention, and all the things, failures, and the gaps, and the justice? Tell us how you feel about the future.
Okay, well, I'm very optimistic. I'm very optimistic. Okay, we've had a 50% decline in risk of colon cancer death since 1980. And by the way, there are states in the United States where blacks and whites have the same colon cancer death rate. We've had a 40% decline in death rate from breast cancer. There are 6 states in the United States where black and white women have the same death rate from breast cancer. By the way, there's 12 states in the US where white women have a higher risk of breast cancer death than black women in Massachusetts. I am very optimistic. We have learned so much. We've got so many drugs. We have drugs now where in the last 10 years, the lung cancer death rate is going down, not just because people stopped smoking 20, 30 years earlier. The lung cancer death rate's now going down because the drugs work in metastatic disease. So I'm very, very optimistic. The goal is to get everybody all of these wonderful things that I'm talking about, and to get everybody all of these wonderful things in a rational way. Because too much medicine harms people, not enough medicine harms people. And the other thing we haven't talked about is, as we've learned more and more over the last 50 years, we've learned the importance of, some people call it prevention, other people call it risk reduction. And we're really working now toward how can we keep some people from getting these diseases. For the last 50 years, the leading cause of cancer in the United States has been tobacco. The decline in use of tobacco is causing a decline in cancer. But I'll tell you what the big problem now is: obesity or energy imbalance. It's not just obesity, it's consuming too many calories, not exercising enough, and then storage of that calories that you don't burn off. That's the obesity part. It's a 3-legged stool. It's not just obesity. That is going to become the leading cause of cancer in the United States within the next 5 years or so.
Wow.
So we need to talk about prevention.
We love your optimism. This is actually a question for both of you. In the chat, Linda, thank you for asking. It's well known that women also have bladder cancer diagnosis. That was little known in society, but we sure know about it at the Greenberg Bladder Cancer Institute. However, often there's a misdiagnosis problem because women are used to, maybe it's perceived as a UTI or some other female issue. And they also have worse outcomes, which is devastating to us and to our everyone who treats bladder cancer. So for David and for Dr. Brawley, we're trying our best, but what do you see as the sort of what will break that cycle of distress, so to speak, in terms of outcomes for women specifically?
You want to go first?
Yeah.
Yeah, I can't get you to call me Otis, can I?
Otis.
I think the only thing we can do is more education, education of doctors, especially education of women in general is, I think, less likely to be fruitful because so few women are actually going to end up having the problem. But the doctors are the ones who are going to see the problem, and the doctors are the ones who, it's due to menstruation or it's a UTI or it's something else, and who put off on the diagnosis of it. Over time, maybe we can also figure out what are some of the drivers that make the cancer grow and more aggressive as well. David?
Totally agree. So firstly, we've got to get the problem of late diagnosis off the table. So ideally, my opinion would be to democratize this. We talked about the TURBT being an art and how there's finally some attention being paid in our community to the idea that the TURBT quality should be measured and research should be done to look at that. And also people should be trained more intentionally to do a good one. But also, I think we need better diagnostics. So Otis mentioned GRAIL. Of course, we're very active in trying to develop urine biomarkers that allow us to tell if there's cancer there or not. And there are companies that are pretty far along in that. So a combination of finding blood in your urine plus maybe a urine test that very objectively and democratically tells you if there's cancer there and preferably how aggressive it is. I think once we get the diagnostic problem off the table, we can start to address what might be underneath that in terms of biology. We do know, for example, that more women get these basal cancers that look like triple negative breast. We don't know why that's the case. We also know there's some differences in mutation frequencies involving so-called chromatin modifiers. We don't know why, what significance that has, but of course the elephant in the room is the hematuria workups often are used. Women are given antibiotics, and we've got to make sure that women with cancer are diagnosed as efficiently and as quickly as men with cancer are.
Say this, that I think there's an Einstein quote that if you've given an hour to solve a problem, 55 minutes of solving the problem is figuring out what's wrong. And I think there's a new movement for women with bladder cancer to understand that it's been grossly underserved, it's been absolutely under-researched, and that there's a full awareness now that a lot can be done. It's only 40 years late, but we're working on it. So I pledge that this is a major part of the portfolio for all bladder cancer researchers, not just
well, we have to push more precision medicine out into the communities somehow. So some of the tools and bells and whistles that we're working on here, maybe we can use apps and wearables and other things to help do that. Maybe it's helping doctors access the level 1 evidence that we've been referring to throughout the NCCN. But we need to focus, I think, on pushing some of this stuff out to the community. Education, as Otis started with. So
yeah, you speak, Dr. Otis. I'll stop there. You speak very passionately, and it was stunning in the interviews and the work that you've done. That you, as a hallmark of a disparity, is education level. Can you share with us those statistics about that, which really surprised me?
Yeah, if you look at death rate from cancer or cardiovascular disease or diabetes, by education level, people who are high school dropouts have the highest death rate from each of those diseases. People who our high school graduates do better. People who are college graduates do even better. And people who go to graduate school do even better. And part of it is if you're, the more educated you are, the more likely you are to have means, such that if you have a issue, say a woman feels something in her breast or a woman sees blood in her urine, she's going to be more likely to go to the doctor and even argue with the doctor to get the services that she needs compared to the person who is the high school dropout. If you are in the system getting treatment, people who are more educated are more likely to be able to negotiate their way through the hospital to get the services that they need. And so they're even more into talking to the doctor and getting better service. So it's not just people who are high school dropouts don't have insurance. That's certainly a part of it. It's not just people who are poorer don't have transportation. That's certainly a part of it. But people who are more educated are more likely to eat 5 to 9 servings of fruits and vegetables, more likely to exercise, less likely to smoke. Those are all part of it as well.
So I want to step in here and make a plug for Rick Bangs, who a lot of you know on the call. Rick, in one of our Southwest Oncology Group trials, actually lobbied to get funding to transport people in to be able to participate in the trial. I think this access, literally getting people driven to their appointments, is really important.
Yes.
If there are any more questions, please send them in. But in the meantime, I'll keep talking. So I have two. During this pandemic, many cancer patients woke up to the world of telemedicine. And in many cases, it worked really well for people. They were at home, they got a medical consult. What do you think telemedicine can help bridge disparities? And do you think it's here to stay?
Every time we have an advancement in medicine, be it a new treatment or a new drug, we actually increase disparities first. And after a few years, disparities start diminishing. The delta goes away. I think initially over the first couple of years, the telemedicine, which I think is a good thing, is going to cause more disparities. But over time, I think things will get better and we will be able to overcome some of these problems with transportation and so forth. I see patients and older people, poorer people, if they have the equipment to do telemedicine, are less able to work it or operate it than people who are a little bit more sophisticated. But I think we're going to get better over time. Again, this is not a reason not to do telemedicine, but I do think it's initially going to create some disparities, but those disparities will start going away over time as more and more people get into telemedicine.
Interesting question and fantastic answer. One of my last questions for you is, I think we should all be grateful, that's my opinion, grateful and proud of this, the speed of the COVID vaccine and the mRNA that we all learned about, and it was utterly fascinating. It's my understanding vaccines for cancer have been in the works for a long, long time and came to fruition. Do you see, what is your view of the discovery process with the mRNA vaccines and its application for future cancer?
Well, I'm laughing because, we're talking about that investment that started 50 years ago with Richard Nixon. One might actually say that the biggest thing to come out of the National Cancer Act was the messenger RNA vaccine for COVID. Moderna was a cancer research company and used messenger RNA to develop some of the first anti-cancer viruses, and they weren't working very well. And Moderna was actually thinking they might have to fold up shop, and then COVID came along. Now, what COVID has actually done is helped us learn a little bit more about how you manipulate mRNA vaccines. We're talking about the lipid covering that goes in them so they can be injected in other things. And so mRNA vaccines are really on the table again as anti-cancer drugs because of what we learned in COVID. And the company that was making the mRNA vaccines, it was saved because of COVID.
Wow, wow. I have another question. First of all, David, our mRNA work, is that being used in bladder cancer?
So we've got a fusion, TAC3 FGFR3 fusion, and the fusion
David,
proteins.
Don't know what you're talking about.
Yeah,
so.
no, the fusion proteins, like there's one in lung cancer too. They look like they might be good vaccine targets.
Okay,
There's
so
some
we're
in
talking about
sarcomas.
vaccine for bladder cancer.
Correct.
Someday in the next 50 years.
By the way, we're okay. In the next 50 years, we're going to have mRNA vaccines and other vaccines that aren't mRNA vaccines for both the treatment and the prevention of cancers.
Absolutely.
Wow.
Absolutely.
With that, we're at 4:55. Please, if anyone else has a question, but Dr. Brawley, it's just a joy to talk to you. And you know, you've had a long career, and you do profess to be very optimistic about the future. What we appreciate most is that you really lay out what the flaws are, and the journey for bladder cancer and other patients is a tough one. It's full of obstacles. It's full of disappointments. It's logistically challenging. And our hope is that someday it just becomes uneventful, successful, and just routine. And that, so my last question, do you perceive that cancer is a chronic disease at some point?
More and more. We're starting to see this in, interestingly, some lung cancers and some breast cancers. We'll start seeing it in bladder cancer soon. The model is more like diabetes. That it's a disease. You know, I literally still have, I used to do breast cancer back 20 years ago, and I literally still have some metastatic breast cancer patients I took care of in 2001, 2002, who are doing very well. They are living in peaceful coexistence with their breast cancer, with metastatic breast cancer. I anticipate there are some lung cancer patients who are living in peaceful coexistence with their lung cancer. I anticipate we're going to have more and more people like that. They're far and few right now, but I think we're going to have more and more people like that. And the model for many cancers is going to be not cure, but living and having a good, productive life with no symptoms or minimal symptoms, but still having the cancer and continuing to get a little bit of treatment for that cancer.
Wow.
I like your analogy to diabetes. I think that's a good one.
Yeah. Last question. If you are diagnosed with any cancer and you still smoke, okay, so you have been diagnosed and you still smoke, is it too late or should you stop smoking?
You should stop smoking. You should stop smoking because within 2 weeks of one stop smoking, oxygenation levels are going to be better. Some cardiac parameters are going to be better. By the way, my favorite anti-smoking study ever done was there's a town in Montana that stopped smoking in restaurants and bars, and the heart attack rate went down in 6 months. Okay, all right. It's never too late to stop smoking, and there's always a benefit to stop smoking as long as you plan on living for 24 hours or more after you stop smoking.
Great. Dr. Brawley, thank you for your kindness, your wisdom, your generosity, and also for these great, this great talk today.
Always
really,
good to see you.
You made us really optimistic too. So thank you. And
thank you.
Keep up
thank
the
you
great
so
work.
much for having me, and thank you for all the support you and Mr. Greenberg give us.
Oh, we love you. Now we'll call you Otis.
Okay.
All right. Thank you, everyone. And we'll see you at the next session coming up. Appreciate it.
Come back in April.
You bet. Thanks
Take
again.
care.
Thank you,
Bye-bye.
Dr.